Good morning, everybody. I just want to say thank you for joining us today, and I want to thank Susan for inviting us to speak this morning. So for this portion of today, we're going to take a little bit of a shift, and we're going to shift a little bit from thinking not necessarily about pain in particular, but we're going to start thinking about culture, cultural considerations, what cultural competency is, and skills that we can all use to develop these intercultural competency skills so that we can better serve clients of different cultural backgrounds and interact with people in general. I've always told myself and tell others that cultural competency is something that's very relatable on a personal level, and it also helps us recognize group cultural patterns. So at this time, I'm just going to provide a very basic overview of what we mean when we talk about culture. We like to go back to this definition where we work, that culture can be defined as a group's shared beliefs, values, customs, behaviors, and artifacts. We also can think of culture as commonly understood, learned traditions, unconscious rules of engagement. So we know that culture is both subjective, it can be both very personal, very individual, and culture is also very objective. In addition to that, when we think about culture, we can think of it as a template of a particular group's fundamental beliefs through which personal identities are created. So in a very basic sense, when we think about culture, think about it as really just a group's shared beliefs, how we relate to one another. And in addition to that, we know that groups also share cultural identities. And it is these cultural identities that are constructed through experiences over time, and this is often influenced by social and historical relations. So what we just learned, I hope, is that as people, we are all cultural beings, and we all have values. And so it is these values that have been shaped over time, over our experiences, through history, through our interactions with one another. And we've also learned that collective group values and identities are based on a shared history and experience. So I just want to take a minute, and I want everybody to just, you can either close your eyes, you can sit there, look down at your feet, whatever, and just individually reflect on what some of your personal values are, and think about what your personal experiences have been, your history, and how these may have shaped what your values are. So in my mind, I'm going to think to 10 seconds, and I'm going to give you an opportunity to think about what your values are. So some of you may have thought about maybe family. Family is important to me. Some of you might have identified the way we look, the way we present ourselves as a value of ours. Some of us may have also thought about being time conscious, being on time, effectiveness. That's a really strong value, work ethic. So where these values come from, I'm going to guess that have come from a place. Either you were taught them, either you've learned them over time. They've probably been shaped by your peers, your social interactions with other people. And these are values that we carry with us whenever we interact with one another. Now I want to ask you to take another moment and individually reflect on maybe what another person's values would be and how their history, how their experience might also have been shaped by that. So I'm going to guess that the values that you thought about were probably very similar to the values you thought about when you were thinking about your own values, right? And for that reason, it just goes to show that we often use ourselves as a point of reference when interacting with one another. we often interpret other people's values and behaviors based on what our experiences have been, right? And that's a very common thing. I think as human beings, that's just what we do. But the important thing to recognize is that the reason behind another person's behavior is likely based on their experiences. It could be cultural, it could be learned, and it's probably shaped by what their, like I said, experience have been. So they may hold very similar values for very similar reasons, but they might hold very similar values for very different reasons, or vice versa. And I always find that if I take a minute to think about what are my values and what am I bringing into this moment, it helps me recognize the beliefs and the assumptions that I'm bringing into my interactions with other people, because I've learned that it helps me identify a blind spot, but it also helps me recognize a similarity where I can bridge that relationship with that person. Okay, so I'm going to stop talking about culture in that sense, and I just want to talk a little bit about Indigenous people. We know that in Saskatchewan we have a very diverse population, and in particular with our Indigenous populations, according to the 2011 census, we had about 15.6% of the population self-identify as a First Nations, Métis, or Inuit person. We also know that we are a young and growing population. We're diverse. There's very diverse and distinct Indigenous groups throughout our province, with very diverse languages, very diverse customs, traditions, values, and so on. But also at a I guess a legal level, Aboriginal people can be classified as either a First Nations, an Indian person, a Métis person, or an Inuit person. And this is really important to recognize the three distinct groups, especially as healthcare providers, because there's certain histories that each group has that helps us recognize when to apply a specific approach to people. For example, First Nations people can either be treaty people, non-status people, treaty meaning that they are recipients of non-insured health benefits, and so on. Oh, sorry, pardon me. So just very, very briefly, I'm going to provide about a 2-minute historical overview of why it's important to understand the history of Indigenous people. And I'm just going to keep it very related to Saskatchewan. So I'm really not going to go into what's happened all over Canada, but I really want to touch to some of the experiences that have happened within our own province, and that's it. So we know historically there is a common and shared experience with systems, with institutions, with Aboriginal people. We have learned about the residential school experience. We have learned about the impacts of colonization. We have learned about how those experiences have disrupted a cycle of balance among Indigenous peoples, how it has affected their relationship with land and the environment, and it's also affected it's also impacted the way we relate to systems and institutions and other people, so our relationships with one another. It has had an impact on experiences with authoritative figures, with governments, and it also has led to intergenerational trauma that we still see today and in today's challenges. And on a micro level, we can still observe this historical impact through our reluctance to vocalize and communicate about oneself. This is something that I learned just recently, that my inability to just communicate on who I was just at a personal level was something that was cultural. It was something that I learned to do and not to do. And it's hard for me to explain that because it's such a personal experience. But it's important to recognize that when people choose to do something, it's coming from a place, and it's coming because of a reason. There's always a root cause to something. So we did our whole overview on culture, what it is, how it relates to a collective identity, and I just wanted to provide that overview of Indigenous people. We don't really have the time to go farther into that, just because I think I only have 5 to 10 more minutes. But I assure you, there's so much information and knowledge out there that if you wanted to learn more, you could either contact one of us or just do your own personal research. But I also want to talk about cultural competency and how this relates to us as healthcare professionals, people who work in the healthcare system, and how it affects our ability to provide that compassionate, client-centered care. Cultural competency, the definition that we like to use is, it can be defined as a set of behaviors, attitudes, systems, processes, and people coming together to work effectively in a cross-cultural situation. So simply put, it's the ability to effectively deal with cultural differences among ourselves, among our peers, and also to bridge those cultural differences, and also when to use cultural similarities as a strategy to provide culturally competent care. So ultimately, the goal of cultural competency would be to provide or to achieve cultural safety. So that means an outcome that respects and nurtures the unique cultural identity of the patients, and where we are safely meeting their needs from a cultural level. Intercultural competence is another term that often comes up when talking about cultural competency. And that also refers to the capability to shift cultural perspective and adapt behavior in a cross-cultural situation. And it's important to understand that intercultural development is a skill. It's something that takes time, it takes effort, and it takes, commitment to. It's not a button that we press. It's not, we don't show up to work and say, now I can be culturally competent and then I'm going to go home and just do whatever I want. It's something that's very personable, that relies on our ability to really recognize what our own cultural values are in order to start recognizing other cultural values and identities. So as you know, in healthcare, the care and services we provide are very diverse people that goes across many different cultures. We know that as a society, we are growing, we are becoming more diverse, and I think we see that a lot in our media, in our population changes, and so it's important that we build these intercultural competency skills so that we can address our cultural similarities and differences, and also barriers. And a good starting point for this, again, is to learn about one's own cultures. There's nothing more important than learning about what your values are first before you can learn about other people's values. So one of the tools that we like to use in the health region, or not like to use, we actually use it, is the Intercultural Development Inventory. And so it's a tool that's been developed out of the States by a man, and his name is Mitch Hammer. And so he owns the rights to this tool, and we've used it with a variety of teams and departments. And what the IDI does, it measures individual and group intercultural development based on one's own experiences. And it places groups and individuals on a continuum. So I won't go too much into detail, but you can always get my contact information. I can connect with people either one-on-one to go a little bit more about what this tool is. But it's a very useful tool when measuring intercultural development. It seems that we have developed this desire to always measure things, and so if you really want to understand what your level of individual or group intercultural competence is, I would recommend utilizing this tool. Another strategy that we like to share with people when they ask us, well, how do I build my intercultural competency? It may seem like a huge task, maybe one that might seem impossible, but it's not. A lot of times our shift in behaviors can be in the smallest things that make the biggest difference. But a good starting point is to start thinking about culture in these general dimensions. And so this same man, Mitch Hammer, he identifies 10 cultural general dimensions of cultural differences. And so these are in sense of self and space, too many S's. And I have a list, so it doesn't make it easier. Another one is communication and language, dress and appearance, food and eating, time and time consciousness, relationships. So again, relationships with people, relationships with institutions and systems, values and norms, learning, work habits and practices. So by understanding these cultural general dimensions of cultural difference should help you start understanding what other cultural patterns are evident in cultures that you recognize as different than your own. In order to build cultural competency and intercultural competency, one must have an appreciative interest in another culture. And so when I say an appreciative interest, I'm talking about an interest that really puts judgment out the window. An interest that requires us to not think about culture as good or bad, or right or wrong, but really an interest that will allow us to develop more neutral, positive feelings around differences, rather than seeing culture as divisive, as something to be feared, and most important, something that is important. We must have a sensitivity to notice cultural differences, and we also must be willing to understand behavior as cultural. In order to learn culturally adaptive strategies, you'll have to really put yourself out there to start noticing your cultural blind spots in order for us to address the cultural similarities and differences that we have. So I have 2 minutes. So maybe what we can, another strategy, sorry. I guess if I have 2 minutes, I can carry on. Another strategy that's we encourage and we recommend is through a cultural engagement and cultural immersion. So while one might choose to read a book, study statistics, study articles to develop our knowledge base, that's great. But a really effective way of building our intercultural competency is really putting ourselves in a situation where we can develop these skills. Cultural engagement and immersion allows us for a real, genuine intercultural exchange, and really allows us to grow and identify what our cultural values are, and to build those developmental skills. So cultural engagement can begin by developing an awareness of one's own culture's existence, thoughts, and environments. It then will require us to demonstrate this knowledge and understanding of other cultures. After that, we can start to accept and respect other cultures. And the final step of cultural engagement would be to adapt care that is congruent to the client's culture. So adaptation isn't the same as assimilation. It's not giving up what your cultural values are, but rather it's recognizing another person's values from that cultural perspective and being able to adapt our behavior when appropriate. And that's really it for now. So with that being said, those are strategies that as people and as groups we can share and we can take back to develop our intercultural competency skills, to start bridging across some of these differences, and really to start understanding where it is those we are serving are coming from. I heard in the previous presentation, in order to get that big picture on a human and personal level, really recognizing a person's background, a person's history, a person's culture will give you that insight on the root causes and a clear picture of who these people are, who the people are you're serving, or sorry, who the people you are serving are. And there's nothing more, I think, client-centered and compassionate than really understanding who it is you're serving. So with that, I'm going to pass it on to Val, and she'll provide you with the next part of the presentation.
All right, thank you, Jade. Well, good morning, everyone, and thank you. My name is Valerie Bradfield. I'm a registered nurse, a certified diabetes educator, and also a traditional medicine bundle keeper. So with that, I'll start my presentation and just give you a little bit of history about where I used to work as a nurse. I used to work at the Prince Albert Grand Council, but prior to that, I worked as an RN on the medical palliative floors and the surgical floors of the Victoria Hospital in Prince Albert. I had done that for a number of years, and with the Prince Albert Grand Council, I ended up working with 8 First Nations communities, North and Central Saskatchewan. So we have communities such as Redder, Shoal Lake, Cumberland House, Wapayton, Little Red, Montreal Lake, James Smith, and Hatchet Lake, which is one of our fly-in communities up north. So just to give you a perspective, you know, the Wapayton is a Dakota community, Hatchet Lake is one of our Dene communities, Redder, Shoal Lake is our Cree, Swampy Cree communities, Little Red is actually a mixture of Lac La Ronge Indian Band and Montreal Lake reserves, and they're the Woodland Cree. So just to give you a perspective of where our communities are and the different dialects, even though we may speak the same language, or we may, like, such as Cree or another language such as Dene or Dakota, just to give you some of that background experience. I did work as an Aboriginal Diabetes Initiative Coordinator for the Prince Albert Grand Council, and became a certified diabetes educator during that time. And I joined Saskatoon Health Region actually in July of 2013 as one of the 2 health navigators when we first started the program during that year, and I became the lead in April of this year. So I would like to thank the College of Nursing and the Ministry of Health for hosting this webinar, and to thank each and every one of you for attending and participating during this event. So with that, I want to start just recognizing pain, you know, the topic of pain, and that pain is very under-recognized and under-treated in people of Aboriginal descent. In part because of the general lack of cultural considerations that we as healthcare professionals tend to overlook or may not understand. We may not be aware of the different ways that First Nations and Métis people express pain or communicate about their pain management needs. So after some consideration, and when we're asked to come do this presentation, I was thinking, well, what you know, cultural considerations, cultural competency is very broad. How can we condense it, and how could we share the information to help reach the audience and be able to help each other understand what our patients and families may go through? And so I decided to share more about what our program does through First Nations Métis Health with the Saskatoon Health Region, and share some real stories to try to help just our audience understand the importance of advocacy, the importance of understanding one's language, the importance of communication, and our own Canadian history to better serve our patients and families that we work with and for. So First Nations and Métis Health began in April of 2013. It is the first program of its kind that occurred in Saskatoon Health Region, and in Regina, they've had their program called Native Health Services for over 30 years. So our program is very new to Saskatoon, a program of this kind within the health region. So our goals through First Nations and Métis Health are to serve, provide, and support an integrated, culturally respectful approach. So we want to ensure improving quality health care, helping build an understanding of unique individual needs and circumstances, and help improve patient-centered care. So I want to talk a little bit about our team and highlight our team members. We have our admin support, so Roseanne Glass, she's the first person, if anyone was calling into our program, she would be the individual that you would speak to if you were to call any of our offices at both RUH or St. Paul's. We have two navigators at Royal University Hospital. Delia Alberg-Sylvester, she's one of our Dene speakers. She's from Michelle Village, one of our northern Dene communities. And Juanita Graham, who is from southern Saskatchewan, and she's one of our Cree navigators and also does Cree translation. And then we have a navigator at St. Paul's Hospital, and her name is Hermeline Bear, and she's one of our Cree navigators from Sandy Bay, or Sandy Lake. And we also have two cultural support, cultural advisors, and one residential school support worker. So Gilbert Kuistep is our cultural advisor, residential school support worker. He's based out of St. Paul's, but he does go throughout the health region to meet with individuals who may need some support. And I'll talk more about him in a little while, as well as our other cultural advisor who just joined our team. Her name is Judy Pelly. And she's half First Nations Metis Health and half the Connecting to Care program. So if anyone had heard about the Connecting to Care program, it's a new pilot program that started this year, and they're doing, what they do is they have professionals, they identified 40 of the top users within the Saskatoon Health Region. I think right now they have a list of 24, but they have outreach workers, they have a nurse practitioner, they have psychologists, and a whole group of interprofessional people that go out and meet these top users of the system and provide those supports right to them, right where they are. And Judy is part of that program as well. We also have our director, Gabe LaFond, who is from Green Lake, and myself as the lead. So I just wanted to give you a little bit of stats, and we will have the presentation available for anyone who would like some more of this information. So just to give you perspective, from April 2014 to April 2015, through our program, from April 2014 to January 2015, we had a complement of 2 staff. So there was myself as a health navigator and my coworker Delia. We were the 2 that started in the program. During that time, we had seen 1,898 clients. We had about 137 referrals, but we didn't properly document that because at the time we weren't catching all the number of people, like the nursing units, the social work, the pharmacy doctors that were calling into our unit and asking for support for patients and families. And approximately 733 walk-ins. So walk-ins could be from either the community itself of Saskatoon, or families coming in from the wards of the units, or even patients themselves coming from their rooms in the hospital. And in February, again, with just 2 of us, we had seen about 2,133. So we jumped up about 100 average people that month, and 158 referrals and 893 walk-ins. And in March of 2015 of this year, we actually expanded to RUH and we hired 2 more navigators. So that was Hermeline and Juanita. And while they joined us during that month, we had seen 2,718 clients. So we actually jumped up almost 600 people seen within 4 individuals, 4 health navigators, 320 referrals and 982 walk-ins. And in April, that's when I became the lead. So we had 3 navigators, and we had seen 2,986 clients that were seen, 416 referrals and 1,097 walk-ins. So just to give you a perspective of the amount of individuals that come in through our program and come to access the service, and the short time that we actually had been running the program. So another part of our service is coordination and liaison. So providing links to health supports and help coordinate things like home care, admission and discharge. So even working with CPAS, connecting patients and families to the social workers. If CPAS is too busy or social work is too busy, contacting the community to ensure we're talking to the home care nurse in the community, helping with those admissions, those discharges, supporting patients and families through transportation, accommodations and meals within the Health Canada guidelines, so following the Health Canada guidelines as well, such as the social work do, and that is for our people who have treaty status. As well as facilitation. So helping patients and families navigate the health system through complex care needs. So this could be people that suffer from multiple chronic conditions such as diabetes, heart disease, maybe somebody had an amputation due to their chronic condition, and they may need services, they may need medical equipment in their community, and that might not be available. So helping patients and families navigate with those complex care needs, connecting them to resources that are available within their community or the Saskatoon area, and also resources that are internal to the hospital. So, such as connecting them to the social worker, maybe to client services, pharmacy, nurses, physicians, spiritual care, mental health and addiction, so whoever the patient may need. And providing a cross-cultural understanding from a patient-centered approach. I think that's the key, and I think I've heard that already being mentioned, and making sure that the patient-centered approach is there. So I just wanted to briefly mention one of my previous colleagues who actually now works for the College of Pharmacy here at the U of S. His name is Jairus, and he has his Bachelor of Science of Pharmacy, but he also has his PharmD. And he was actually one of the first First Nations people in Canada to receive his PhD in pharmacy. And so he gave some examples, and if you ever get the opportunity to invite him to come and share some of his experiences on pain, I would welcome that, and let me know and I can connect him to you if he's free and available to do that. But so one of the experiences that he mentioned was how Aboriginal culture and therapies for pain have collided. When a First Nations man did not want opioids because it may interfere with his dreaming. So that was his fear. The pain medication may interfere with his dreaming, so he did not want to take it. So, and with that, what he mentioned was that the dreams is how he receives messages from his ancestors and his spirit guides and his helpers. So just to understand that spiritual perspective. And with this story, it's important to understand the spiritual aspect of one's health as well. Within our Western European health systems, we tend to focus on the physical aspect of a person's health. And as most of us are aware, and we do talk about this within our healthcare, we talk about the mental, emotional, physical, spiritual of one's being, right? And but we always tend to focus more on the physical aspect of that individual. So, and one of the biggest components we do miss is that spiritual component. So really understanding where that patient is coming from and trying to better understand how can I support you in that way. What else can we do to help you with your pain management? Is there a resource that we can connect you to? What do you do? Like some cultures would, do some prayer or meditation, or within many First Nations and Métis cultures, we would do smudging or ceremonies, to help with that balance. And also in many First Nations culture, a medicine wheel is used to explain this concept of the mental, physical, spiritual, emotional being of oneself. So with that, I wanted to go into communication or translation, interpretation. Staff, we have staff within our program that can translate in Cree, Dene, and Soto. And translation, we do that either through the admission, medical procedures, recovery, and do some language interpretation to help promote that cross-cultural understanding. And so I wanted to share a story of my coworker, Delia. When we first started at St. Paul's, we haven't expanded to RUH yet. And she was called to RUH to do some translation for an individual that was from Dillon, so one of the Dene communities. And he was an elderly gentleman, and he did not speak any English. And he had been flown down into Saskatoon at RUH, and they needed to insert a pacemaker because his heart was very poor, and they needed to have that procedure done to help save his life. And he was refusing. He did not know what was going on. And when she went to go meet with him, she talked to him, and she explained what was going on. She explained the medical procedure, and she explained why he needed it. And after she had that explanation and that human conversation, he went ahead with the procedure. It was successful. He was able to go home healthy, and she followed up with him after he was discharged, and he was doing very well. So just the importance of the language and helping bridge that gap of miscommunication and, the language barriers that many of our patients and families face, to help better provide them that support. And so it is important to know your resources and to find ways to help improve the communication process. So advocacy, which is huge for our job and huge part of what we do within First Nations Métis Health. Helping staff and clients better understand complex care issues, communication between staff and clients. There are many instances that our navigators are pulled to the floors just to help build that communication. Being a voice for those who may need assistance, promoting cultural competency and consideration of staffs and services, and addressing issues where they occur. So another example that Jairus had shared actually happened within our own health region. And there was a First Nations female that had been crying in pain, and she had an abscess in her brain and osteomyelitis of her spine. And the physician at that time wrote a big sticky note on the front of her chart that said no narcotics. And he did not see, or he or she, I'm not sure, did not see her for hours despite the audible expressions of pain coming from the patient. So these are real stories. This happens all the time. Unfortunately, it happens all the time. So these are things that we need to be aware of. As healthcare professionals, I know this is not who we are. Our own judgments, our own misconceptions, and the ideas of patients and families we work for should not guide the type of care that we provide. So we really need to be self-aware. There are frameworks that we can build together to help each other better understand our patients from their own client and patient perspective. Part of our role is to become more aware of our own judgments, our own biases, our own assumptions, and our own Canadian history to really truly understand what many individuals have gone through to get to where they are today, or the reason why they may be in hospital, right, or be in your care as a healthcare provider. So I do want to take this time, I know I only have a few minutes left, but especially to talk about the residential school experience. Jade did mention that a bit. But our cultural advisor, Gilbert Kiwistep, he's from Yellow Quill First Nation, and he has a very powerful story. So if anyone gets the opportunity to hear his story, I highly encourage you to. He has been meeting with health professionals within the health region and sharing his story about his own experience of residential school. And he has his master's in social work, and he currently works within our program. And he shares his experience as a child growing up with his culture, knowing who he was, receiving the love from his grandmother, and then how he was taken away to residential school. It's very hard for him still to speak about that experience, but he does share certain things about the residential school experience, and really about the loss of love, the loss of identity, the loss of language, the loss of culture, and how that affected him later on in his adult years. And only until he recognized and reconnected with his culture, his own language, and his identity was he able to overcome these experiences and the pain, loss, and anger, the grief that he suffered. And I do want to remind you that the last residential school on record did close in 1996, and that was in Saskatchewan here. So rates of painful symptoms and painful conditions are higher in Aboriginal populations. On average, 1.5 to 3 times higher, depending on the condition. And that was from Jimenez et al., 2011. There is significant impact of traumatic events on the function and structure of the nervous system. Exposures like residential school experience can have long-lasting negative effects on how pain is experienced by changing the sensitivity of the nervous system and immune system, making people more susceptible to pain conditions. Learned behaviors, such as not overtly demonstrating pain behaviors, have been passed down from residential school survivors to other family members, so Aboriginal people may be less likely to behave in a way that non-Aboriginal healthcare providers may expect from someone in pain. So I just wanted to share some of that information with you. I'll definitely make sure that information is included within the PowerPoint. And I do want to mention briefly, I'm almost done here, the special projects that we had completed through our program, chart audits that we had completed at St. Paul's and RUH, indicating the length of stay for especially our northern residents. They tend to stay longer because they don't have pharmacies in their communities, they don't have doctors, physicians, nurses. And so it takes a lot longer to order their supplies or medications and things like that. So those are things that they find extends the length of stay, as well as the presentations that Gilbert and myself, I mentioned earlier that I'm a traditional medicine bundle keeper. I'm not a medicine woman or anything like that, so just to clarify that, I did receive 4 years of traditional medicine teachings in Peguis, Manitoba. And I'm a bundle keeper, but I do share some information on traditional medicine and conventional healthcare, just to help people understand the importance of understanding the use of traditional medicines, and that they are still being widely used, but many of our communities won't share that with our healthcare providers. Because there tends to be that fear and that stigma that if we use the traditional medicine, they're going to take that away from us, or there's going to be implications. So that's one of the presentations that I speak about as well. And an Aboriginal Health Summit that was actually part of an Aboriginal health strategy, creating actions moving forward. So ensuring that we hear the voices of our communities to be able to continue to work together as a whole team. And as well as numerous councils and committees, but we do have First Nations and Metis Health Councils, the Aboriginal People's Patient and Family Advisory Councils. So just so you understand that it's important to get that voice, it's important to get that experience from the group of individuals that are there that are representing, so that we can better understand each other, as well as different committees that we participate in, and conferences that we've been involved in. So our office is located at 2 sites currently at Royal University Hospital. Our number is 1306-655-0166. And our office is located on the 5th floor, room 5408. And at St. Paul's, that's where our health navigator, Hermeline, and our cultural advisors, Judy and Gilbert, are. And the office number there is 1306-655-0518. And they're located right on the main floor of St. Paul's Hospital, right beside Tim Hortons. So if you guys stop there for coffee, you'll know. Just go right to the office right next door. And as well as the Aboriginal Client Representative, we do have an Aboriginal Client Representative within the health region. who does meet with patients. If they are having difficulty phoning in, she will go and meet with the individuals. So want to inform you of that. And as well, we will take questions at the end. We will be here till the end to be able to answer any questions that you may have. And with that, that's it for my presentation, and thank you.